We will now have our second CME grant lecture sponsored by AstraZeneca, with a topic entitled, Dapagliflozin, Forxiga, Shaping the Management of Patients with Chronic Kidney Disease.
Our speaker is a diplomate of the Philippine Society of Nephrology, Fellow of Philippine College of Physicians, President of Philippine Society of Nephrology Southern Tagalog Chapter from May 2019 to July 2020. Present Director of Research Institute of Perpetual Help Medical Center Biñan. Past President of Philippine College of Physicians Southern Luzon Chapter June 2020 to May 2022. Let us all welcome Dr. Maria Rhodora de Lara Valenzona.
Good evening, everyone. Thank you for allowing us, me and Astra, to present to you this new therapeutic modality for patients with chronic kidney disease. So these are my disclosures, and I know that I am intelligent because I know that I know nothing. So this is something which I have to disclose also. I cannot teach any of you anything. I can only make you think of what I will discuss today and propose that you learn from what I will say. So these are the objectives of my presentation. More than 7 million Filipinos have chronic kidney disease, and this is the data as of 2021. And if you look at it, there is one Filipino who develops chronic kidney disease every 40 minutes. That is around a lot of Filipinos going into dialysis, with one Filipino with chronic kidney disease needing dialysis every hour. So this is a big thing for patients, particularly in our country, when finances will be drained with chronic kidney disease and dialysis. The sad part about it, if you look at this data from the US, patients who have cholesterol dyslipidemia, around 69% are eligible for statin, and they know it, and they are being given statins. So this is dyslipidemia. Patients with diabetes, 79% of the patients who are actually diabetics are known and diagnosed to have diabetes. But if you look at patients with chronic kidney disease, it's a measly 10% of the total patients with chronic kidney disease who are diagnosed. And by that time, and this is at the stage where it's already stage 3, and such a progression is only known around 10% for patients with chronic kidney disease. Comparing this, you see the sad state of patients with chronic kidney disease and the awareness in terms of the diagnosis of chronic kidney disease. If you look at the causes, the etiology of your patient having, the reason for your patient having chronic kidney disease, majority
Recording stopped.
will be because of diabetes, around 42%, and the rest, around 58%, will be for non-diabetic causes. But if you look at that part for the non-diabetic part of it, around 18% will be patients with hypertension. So diabetes and hypertension is nothing which is uncommon. It's actually the bread and butter of our OPD. We see these patients daily in our OPD for our clinic. The sad part is, even if we see a lot of patients with diabetes and hypertension, the prevalence and incidence of dialysis, of patients having dialysis and ending up in dialysis, continues to rise. And as of this data, and it's only updated up to 2016 or 2015, whatever the cause is, wherever it is, dialysis continues to increase in number. Diabetes and hypertension both has this effect on our RAS system, which actually causes the inflammation, endothelial dysfunction. If it becomes chronic enough and not addressed properly, will lead to ischemia and fibrosis and oxidative stress. And whatever happens to the heart will eventually happen to the kidney. What happens to the heart and the pathophysiology and the effect on the heart is pretty much the same that will end up with your kidneys. So it's the cardiorenal continuum that we see here, that the effect of one would also be an effect on the other. So could they go hand in hand? Patients with chronic kidney disease will eventually have heart disease. Patients with heart disease will eventually have chronic kidney disease. And the life expectancy for this subset of population would actually be shorter compared to those other patients in the early stages of chronic kidney disease. When you look at the mortality and the reason for mortality in patients with chronic kidney disease, if you look at the reason for ESKD, CV mortality and non-CV mortality, at a lower part of your, a better eGFR around 45 to 60, you actually see with the trend that more of your chronic kidney disease patients would actually be having cardiovascular mortality or dying from a non-cardiovascular cause than them ending up in dialysis. And this is also true at a lower range of eGFR. More patients will actually die, whether it be from a cardiovascular event or a non-cardiovascular event, than them actually ending up in a dialysis chair being dialyzed by us. So the risk for a cardiovascular event is indeed higher, in fact, even higher than them having dialysis or ending up in dialysis. So how are you prioritizing management of your patient at risk for chronic kidney disease progression? Tonight, I will show you two patients. One of them, Flor, is hypertensive and has dyslipidemia. And if you look at her profile, she actually has already exercised dietary advice, already on good medications. Her creatinine is not that bad. It's around 1.2 milligrams per DL. This is actually normal if you look at it in terms of the laboratory parameters. And we will also look at Felix. Felix, on the other hand, has hypertension. He has diabetes and he has dyslipidemia. So the add-on here is that he has diabetes. If you look at Felix data, he also has been doing exercise. He's on a dietary advice. Also good drugs to control all the factors that needs to be controlled. However, his serum creatinine is a little bit higher. For a normal serum creatinine is 1.5. Felix serum creatinine is 1.56, so a little bit higher, just a little bit higher. My question to you is, would you be treating them both the same way? Will you be more worried with one or less worried with one, or is it pretty equally the same way that you're going to manage this patient? And another thing is, which of this patient has chronic kidney disease? So these are the things that you need to know. I'm sure that both of them, you have RAS blockade, as I showed you earlier, to treat the hypertension. What else can we do? Because as I said earlier, both of them will be at risk for progression of chronic kidney disease, ending up with heart failure, ending up with death. So how are we going to manage these two sets of patients? First of all, you need to diagnose, does Flor have chronic kidney disease? How would you do that? The first thing to do is for you to check the kidney function by checking your eGFR. And you do this by getting the CKD-EPI. You convert your creatinine to your eGFR. And patients with less than 60 ml eGFR is considered chronic kidney disease. You worry about them. Albuminuria, by getting your urine albumin creatinine ratio, is a measure of your kidney damage as compared to eGFR, which is a measure of your kidney function. And for patients with an eGFR of less than 60 or albuminuria, which is significantly increased more than 30 milligrams per gram for more than 3 months, your patient is already labeled as chronic kidney disease. So why is this important? Because there's this heat map that we need to categorize them. And just like the traffic light, we have the green, the yellow, and the red in terms of warning us that patients with a lower eGFR, lower eGFR means worse or lesser renal function. Higher albuminuria means more damage for your kidneys. And if you look at it, as you go through the lower part and as you go through the right side, it turns red. So this means patient will be at a higher risk for progression. These are patients that we need to watch out more. This table now shows how often we need to monitor. For the green light, it's only once a year. For the yellow light, at least once a year. Orange is twice a year, and the red one would be 3 times or 4 times a year. So the higher the albuminuria, the lower the eGFR, the more frequently that we need to check the eGFR and monitor the urine albumin creatinine ratio for these patients. As per recommendations, those on the red side and the highest degree of albuminuria, you would need to have a nephrologist, and it's recommended that you ask a nephrologist to be on board to help you manage these patients because of the higher risk. Throughout these years, what we'll be giving our patients are ACE inhibitors, RAS blockade, and the more common ones that we give will be your losartan. But if you look at it, even if your patient has losartan, you have that residual risk of your patient still having the progression of your end-stage kidney disease and their patient dying by around 43.5% mataas, that you still would have that event, even if your patient is on a RAS blockade, for this case, losartan. So with this, we know and we feel, and it is a reality, that there's a need for more novel therapies to improve lives and outcomes for chronic patients with chronic kidney disease. And I would like to pose to you the dapagliflozin and the benefits of dapagliflozin, because there are studies already throughout the range of eGFR, whether the patients have good eGFR or whether they are at the higher stage of their chronic kidney disease. This is the DECLARE and the DAPA-CKD study. And this study shows us and would tell us that dapagliflozin will give our patients the benefit in terms of the patients and the progression of chronic kidney disease. And as with the DAPA-CKD study, this could be given across the continuum for even a GFR of 25 ml per minute per meter square. The DAPA-CKD study shows this, and if you look at it, the inclusion criteria, as I said, as low as 25 ml eGFR, as high as 5 grams of your protein excretion. They're already on RAS blockade, which is a standard therapy for these kinds of patients. And the population included around 67% with type 2 diabetes and around 32% without type 2 diabetes. So patients with and without diabetes are included in this study. Again, majority of the patients would have an eGFR of around 30 to 45 and a significantly high albumin excretion of more than 300 milligrams per gram. What does the DAPA-CKD study show us? The DAPA-CKD shows us that both for the primary composite outcome and the renal specific composite outcome, you have the benefit of reduction in renal events by around 39% and 44% respectively. For cardiovascular events, you have a decrease in CV death and hospitalization from heart failure by around 29%. From death, both for the renal composite outcomes and the primary composite outcomes, for all-cause mortality, we have that benefit of a relative risk reduction of around 31% for patients on dapagliflozin with chronic kidney disease, whether they have diabetes or without diabetes. So how are you going to integrate this evidence to help Flor, to help Felix, or any patient with chronic kidney disease? For Flor, when we look at her, let's look at Flor. Look at where she is in the heat map. This is her eGFR. This is her albuminuria. So if you look at it for Flor, even if the creatinine is still normal, she's already at yellow. So she's already warning light, because the risk for a cardiovascular event, the risk for progression to chronic kidney disease is already at warning. So medyo mataas na sa kanya because of the albumin excretion which she has, which is 250 milligrams per gram. So if we give Flor dapagliflozin, if we're going to apply the evidence of the DAPA-CKD study, if you keep Flor on dapagliflozin by 8 months, you see a decrease in her risk. She is non-diabetic with chronic kidney disease. You see the risk for progression of chronic kidney disease, progression of cardiovascular disease, or dying from a cardiovascular disease or a renal event by around 50% relative risk reduction. If you keep her on dapagliflozin by as early as 8 months, you see that benefit for Flor. How about the secondary composite outcomes in terms of renal death? Again, as early as 8 months, you see that benefit by around 49% reduction in terms of Flor dying from a renal event or cardiovascular event or a progression of your chronic kidney disease. Again, Flor has no diabetes, only hypertension, patients with chronic kidney disease. Again, for chronic kidney disease without type 2 diabetes, how about all-cause mortality? Will Flor be dying soon? What is her benefit in terms of preventing death? We see that for patients like Flor who has no diabetes but with chronic kidney disease, from the onset, from the start, when you put her on dapagliflozin, you have a 48% risk reduction in terms of all-cause mortality as early as a month when you start Flor on dapagliflozin and maintain her on dapagliflozin as compared to those not on dapagliflozin. How about the adverse events? This is an oral hypoglycemic agent. Will you be seeing more hypoglycemia? If you look at it, there is not much difference in terms of hypoglycemic episodes, even if your patient has no diabetes and you keep them on dapagliflozin. So you don't need to worry about hypoglycemia, even if your patient does not have diabetes. How about when we look at Felix? Felix is hypertensive, she has dyslipidemia, she has diabetes, and as I emphasized before, his creatinine is a little bit higher, is in fact a little higher than what is normal. When you convert it to eGFR using the CKD-EPI formula calculator, we know that his eGFR is actually 51 ml per minute per meter square. And if you check her albuminuria, his albuminuria is actually a little bit lower than Flor. And you see that this is where he is. He's already at stage 3B. For the albuminuria, he's already at stage, she's already at stage 1. Sorry, I made a mistake there. And if you look at it, he's already here at this part. So he's already red. So if you look at it, even with just a slight elevation of your creatinine from normal, Felix is already stage 3. And that would mean that he has the highest risk for a cardiovascular event and progression for chronic kidney disease. So we look again at the evidence of DAPA-CKD, this time for Felix, someone who has diabetes with chronic kidney disease. Pretty much the same. You have a relative risk reduction. She has that benefit of 36% relative risk reduction. And you see that benefit earlier on as compared to that of patients without type 2 diabetes. It's as early as 4 months. You see that protection for patients like Felix in terms of declining kidney function, end-stage kidney disease, or renal or CV death by 36% as compared to those patients not having diabetes, as I said earlier, which is around 50%. Again, for patients with like Felix with type 2 diabetes with chronic kidney disease, in terms of the secondary outcome of sustained decrease in your eGFR, pretty much the same as Flor, who is non-diabetic. At 8 months, if you keep Felix on dapagliflozin, you will see a 43% relative risk reduction. And if you want to compare this to Flor, someone who is not diabetic, it's pretty much the same, around 49% for Flor, who is non-diabetic. So same benefit. How about patients for DAPA-CKD secondary endpoint in terms of risk mortality? For Felix, who is diabetic, you see that benefit again earlier on, and that's around 46% as compared to Flor, who's 48% in terms of reduction of all-cause mortality. So you also have that benefit for patients with type 2 diabetes as well as those who does not have type 2 diabetes. Again, if you look at the adverse events profile for patients with CKD and type 2 diabetes, there's not much difference in terms of adverse events, whether it be for hypoglycemia or volume depletion, not much difference for CKD patients with type 2 diabetes. If you look at both, whether your patient has CKD with or without type 2 diabetes, for exploratory outcomes in terms of chronic dialysis, the need for kidney transplantation, or renal death, both of them will have that benefit of around 34% relative risk reduction as early as 8 months. When you keep them on dapagliflozin, you see that benefit for this particular outcome. How about the eGFR part of it? Again, we see that decrease, and this is true not just for dapagliflozin, but for all SGLT2 factors. There's that acute decline in your eGFR at the onset, which is around 2 to 4 weeks from the start of your dapagliflozin. And if you look at it, there is a lesser decrease, a sharper decrease in your eGFR for those not on dapagliflozin as compared to those on your dapagliflozin. And when you want to check the numbers of it, by around 12 months, you would have a lower eGFR for patients on placebo as compared to those patients on dapagliflozin. And the decrease in your eGFR, the annual decrease, would actually be around 3.5 for patients not maintained on dapagliflozin as compared to those on dapagliflozin whose decrease is only 1.6. So half that of those not on dapagliflozin. How about your albuminuria? With the decrease in eGFR, we also see that concomitant decrease in albuminuria on patients with dapagliflozin, and you see that this is sustained, the decrease is sustained all throughout the study. And if you compare it to that not on dapagliflozin, you see that there's a significantly more decrease in your albuminuria when you are on dapagliflozin, around 42% reduction in albuminuria with dapagliflozin. So we have to remember that our patients here as low as 25 ml eGFR. So lower na po, we can start patients on dapagliflozin even if your GFR is 25. So 25 and above, you have the benefits which I discussed earlier, and you can initiate your patients on dapagliflozin for you to see the outcomes which I said earlier. So with this, despite the fact that we have more patients with chronic kidney disease, despite the burden being there, we have to realize that we have to be on the lookout for it. We have to screen the patients. And because of the DAPA-CKD study, which is a landmark study for both non-diabetic and diabetic patients with chronic kidney disease, we have a newer armamentarium for patients with chronic kidney disease. And for dapagliflozin, we have the DECLARE and the DAPA-HP, which also tells us that even patients without chronic kidney disease will have that benefit in terms of cardiorenal and mortality outcomes. So with this, I would like to remind everyone that nothing ever goes away until it has taught us what we need to know. Diabetes, hypertension, chronic kidney disease has not taught us everything. We still need to continue on being on the watch. We still need to continue learning and finding out new ways to address this and to help the outcomes of our patient. Sabi nga ng patients natin, una ang Diyos, susunod tayo. And prayer indeed is good, but while calling on the gods, a man should himself lend a hand, and we as doctors should lend a hand by giving newer therapies and considering newer therapies to help improve the outcomes of our patients with chronic kidney disease. So with this, thank you for the attention, and I welcome questions with regards to what I presented.
Okay, thank you, Dr. Valenzona, for the very inspiring and comprehensive topic for tonight. Is there any questions from the virtual floor? No questions?
I see a question here in the chat box. It's asked, when do we lower the dosage of dapagliflozin? You don't actually lower it. There's only one dose. You start at 10 milligrams and you keep them at 10 milligrams. You start even at a GFR of 25. You keep them on that. There will be that transient decrease in your eGFR. You don't stop it when you see the decrease in the eGFR because that is expected. You need to keep them on that even if the GFR goes below 25. But you initiate at 25. So there's no dose adjustment. You keep it at 10 milligrams. That's one comment.
Okay, thank you, Dr. Any questions? I think since we have the limited time, I think Dr. Valenzona, thank you very much for Great. No questions anymore.